so the last customers speaking today are a couple of the team from Sussex, from Sussex. We're going to be talking about their experience in governance work, which again, we use Bill Exemplary, but genuine Bill Exemplary, which is why I wanted them to speak today about getting pathology results into the records. So Susan and John are going to speak. I think Susan is going to be kicking off if you're there.
Yep. Thanks, Sarah. Hi, everyone. I'll just go straight to the next slide, please. I'm just going to give a very quick introduction into who we are, I suppose, and then hand over to John, who's got the really interesting part of the presentation for you. So our instances of PKB are across the ICS, as known as My Health and Care Record. You can see our branding up there. And our trust works in very close partnership with the Sussex Health and Care Partnership digital program. It represents community primary secondary care across 17 organisations and about 1.7 million patients. So it's a fairly big patch. Our trust, University Hospital Sussex, merged from Western Sussex and Brighton Sussex in April of this year. So if you haven't heard of us before, we've become a little bit bigger and more complicated in the last 6 months. We've currently got around 120,000 patients registered inside PKB, and we're sending centrally booked appointments from our PAS systems, which represents about 60% of our outpatient appointments, discharge summaries, and we're working on clinic letters and results, which is the key focus of the presentation today. We are working on virtual clinics as well for remote monitoring for renal, physio, cancer, and bariatrics. Next slide, please. Really, I mean, our ambition for PKB is very, very similar to what we heard from Neil Perry earlier today, to reduce unnecessary appointments, reduce DNA rates, and relieve the pressure on the front door through minimising avoidable admissions, and of course, empowering patients by putting all of their information in their hands. And I suppose I just wanted to make the point before I hand over to John is that we've actually been at this for a couple of years, and it's been a bit of a challenge for us to get the critical mass and the change that we've wanted to see from both patient and clinician behaviour. And I think probably one of our key learnings is that we probably tried to run before we could crawl, and that we wanted to leap into wearables and virtual clinics and all of that kind of stuff. And we're sort of starting to turn the corner with those things. But our realisation was really that if we couldn't make the record richer for patients, we weren't going to see that buy-in, and that really encouraged us to change the focus to getting as much information into the personal health record as we can. And that's where we started with our results, and it's time for me to hand over to John. Thank you.
So my name's, I'm John Laurie. I'm a clinical haematologist by trade. So I have a bit of background in kind of lab work already. And I've been involved with the kind of PKB for a couple of years now, really kind of focusing on the release of results to patients, which has kind of gone through a number of different interpretations over the last couple of years, but we're really managing to gain some traction now. This all kind of started with really the NHS constitution saying that really all of these results belong to patients in the first place, and actually they should have access to everything. And certainly within our region, patients had bitty access to the results already, either through the NHS app, or an awful lot of the primary care practices had individual apps. But really, they mainly relied on GPs releasing individual results to patients that they felt would benefit them and not worry them too much. And so that was a huge workload on the GPs to actually do that. And to my mind, kind of betrayed the principle of the fact that these results should be given to patients in the first place. The projects went through a kind of number of different iterations. So we started off with Western Sussex, which is where I started things. And then kind of in the middle, they decided that maybe we should expand that to all of Sussex. But it became quite rapidly clear that that was going to be exceedingly difficult to do. And so we kind of contracted it back down to just the Western patch to begin with as a bit of a test bed, so we could get things right and the proof of principle to the other lab departments that it was possible to do and nothing was insurmountable. From a governance point of view, we've had a lot of discussion previously at a variety of different levels about how we were going to go about doing this. So at the Trust, we have a digital outpatient transformation board where that was discussed about how we were going to implement it, and also went up to ICS level where we had clinical representatives from all the different areas within Sussex itself. So that's primary care and the psychological services and everyone else, the acute trusts as well. So it was discussed there, and that was then fed back down to the various different groups below them so that everyone was aware of what we were trying to do. And probably as many people on this call will remember from their own experiences, there's a lot of anxiety, especially amongst the healthcare professionals, about exactly what this was going to involve. And the problems that may happen from it. And a lot of people are worried about whether patients were not going to understand the results, whether we would cause distress to patients by releasing results that potentially had big implications like cancer diagnoses, etc. And I think the biggest concern that we had from pretty much every quarter was, am I going to get lots of phone calls from worried well patients looking to try and understand the results? My kind of philosophy on that was I would much rather have a patient who had a very serious result that potentially got missed, phoned up for information, so that was caught. And that was really kind of one of the biggest benefits I saw in doing this. I can have the next slide, please. So we decided to go live with blood results first of all. So certainly our aim is to release all pathology results to patients, but we decided to start with blood sciences first, mainly from an IT point of view. That is far simpler. But the next plan will hopefully roll out in the early stages of next year will be the microbiology results, which, as they're more text-based and interpretive, are slightly more difficult to do. And then following that, it'll be the histopathology results, which are actually far simpler in many ways. But because we send a lot of things out of region for second opinions, we're having a slight problem trying to work out how we're going to manage that. The overall plan is that we will release all results to patients in real time, apart from anything that might cause undue distress. And so what we ended up doing was creating a test repertoire for the hospital, which was not too difficult working in the labs, and then going through all of them and deciding whether or not something would be released immediately to the patient, or whether we would put a standard 28-day delay onto that result. And so that result would be available to the clinician. A message would go to the patient saying that this result will be released in 28 days. And that's really just been applied to sexual health results and to tumour markers. When it comes to microbiology, that will probably all go out straight away as well, apart from the sexual health things, and then all histopathology will automatically have a 28-day delay regardless. And we went out and we spoke to the patients about that. So when we were releasing the results, we sent out information to the people who were already signed up to My Health and Care record, explaining what we were doing and what the guiding principles were, and exactly why we were having this 28-day delay on certain results. As an additional kind of governance method, we've also created rules within the system as well, that if a result doesn't have a rule attached to it, i.e. immediate release or 28-day release, then it would automatically default to a 28-day release, so that things don't slip through the cracks at all. And so we've now got this up and running, and has been running since May. And I say there's plans to do the rest of the pathology results for the West over the course of the next number of months. And then that will also be released to the Brighton Hospital for UH Sussex East sometime next year, and Esht as well over on the other side. I can have the next slide, please. This is just an example, excuse me. This is just an example of the test list that we produced. So there was a small working group amongst the pathologists at the hospital. We went through everything just to make sure that it wasn't all relying on one person's discretion. And so this was the test list, and that was then applied to our limbs as it goes into PKB from the tie. The next slide, please. So there was a prolonged period of engagement and consultation with a number of the different users. We did have patient representation on some of our work groups as well, just to get their endorsement. But we kind of discussed exactly what we're doing with our informatics lead, which is kind of system-wide. There was a number of primary care physicians on the ICS panel, and then there was myself and Hilary O'Connor, who were based at Western, to champion this and kind of move it along. The pathology board is the main governance and sign-off board that we've used to take everything forward. We've had a number of presentations, both within the trust, so chiefs and CDs, and then out at kind of the more kind of medical consultant level as well, so that people were aware of what was coming. And there was presentations that went out to primary care as well. And we've had kind of regular meetings since go live just to try and refine things and pick things up as they've come up, which thankfully have been pretty minor so far. We have had a few items of feedback from consultants and GP practices who were unaware of things going out. There has been a lot of communication, so I'm not sure how they managed to miss it, but there was a little bit of pushback when it came. But actually, I think I've had about 3 or 4 kind of emails that were grumbling about it, and actually overall it's been quite positive across the board. So the other thing that we have been doing, I think is on the next slide actually, was that with the 28-day delay things, so anything that has had a 28-day applied to it, which we weren't expecting, we've been going through the list on a monthly basis so that anything that was missed on the initial sweep through has proper rules that are attached to it as well. We've got in the communication that we sent out to patients as well as the GPs, we've been very clear that we do not want patients to contact GP practices or contact the hospital unless they were particularly concerned about something. And we've very much tried to steer them to the person who requested the test in the first place and to wait for their next appointment to discuss any concerns that they have. However, if they did have any concerns that couldn't wait, there was an email address that was set up and monitored by our IT team, and any clinical questions answered by myself, so that they did have a point of contact where they could get support if they needed it. And again, I was expecting a lot more than what's actually happened. We've had probably about 10 or 15 emails in total since May, and for the most part people have been quite happy to try and interpret the results themselves or speak to their clinician. One thing that we didn't mention is within PKB, you may already know this, but attached to every result, there's a link to My Blood Test Online, which is a kind of national website that describes to patients exactly what tests mean. And so they're able to use that hyperlink to go and actually educate themselves on that. Thank you very much.
Thank you, John. Really appreciate it. We haven't got any questions in at the moment, I don't think. So we'll just give people a minute because I'm sure there will be some.
So sorry, there was a question from Supratic saying he feels uncomfortable about immediate release to patients without being vetted by the requesting clinician. John, that'd be quite useful to. But how did your, because some of your colleagues must have felt uncomfortable as well. How did you navigate that for them?
Well, I mean, the lab produces millions upon millions of results every year. You cannot vet every single thing and individually choose what to release to patients. First of all, that's not really workable. And second of all, it's kind of what we wanted to move away from with what the GPs were already doing. So they were choosing which results to release to patients and which not to release to patients. And, you know, for me, I think that's quite paternalistic. And I do understand the reticence to do it. It's a sea change in the way that we practice, really. But you know, these results belong to patients. I think other places have put smaller delays on all results, so you can choose within your tie just what delay you want to put on. Some places I've heard of put a 1-hour delay on so that clinicians, especially in the acute setting, because this is released to inpatients as well as outpatients, have time to see a result and potentially act on it. But I think the longer the delay that you put on results, the more you dilute the power of this technology, really. And as I say, there's actually been very little pushback from both patients and from clinicians, for the most part, about stuff being released before they were ready to see it. I'm not sure if that answers your question.
I think it did. Thank you. There's a question that's come in that says, do you feed results to the categories in the record, i.e. general health, sexual health, mental health?
I don't believe so, but at the moment we're only using blood results anyway. So we're talking about biochemistry, immunology, and hematology results. We don't release transfusion results at all. As I say, microbiology would be separate. At the moment, our sexual health services use anonymized lab testing anyway, really. So until they are ready to move back to using proper patient details and NHS numbers, then sexual health results will be separate anyway.
Thank you. And Martin, I know there's a quite extensive comment here from you. Is there a question that you wanted to particularly pick out of that for John?
No, I think it was mostly me rambling, Sarah, sorry.
No, I just wanted to give you a chance. There was a question to pick out of it.
Yeah, just as John and Susan started talking, my Zoom crashed on me twice, actually. So I missed the beginning. And lab results is something that's very high on my radar at the moment, because as I mentioned there, we're just kicking off the project here with the local 2 trusts. So very interested to kind of link in and have a chat really about some of those experiences you've had and our approaches as well, really, in the future. That's all.
Yeah, I mean, we've actually done something very similar for another trust. So I'm very happy to have half an hour with you and your team, if you'd like to just, we can talk through in a bit more detail just exactly how we approached everything.
Yeah, that's really appreciated. Thank you, John.
Thank you. That appears to be the last of the questions. I'll give a minute or so just in case there's not any more, and then we can move on to grilling Mohammed with the ask the questions. I think that's it for you, John. I think you escaped. Thank you very much. We really appreciate it. I know you were in clinic this morning and joined us just in time, so thank you for giving time to be.
I have to run off and leave you, but I hope you enjoy the rest of the presentation.
Thank you. Very much appreciated. Bye.
Bye.